Thank you so much. Thank you so much to Dr. Mallikarjun, um, who has who is the backbone of IACP organization, and I would like to thank all the office bearers um, and those associated with IACP for this opportunity. Um, there is something called 80-20 rule. Um, I'm sure many of you will have heard of this, that 80% of the work is done by 20% of the people. So by taking the time out to join us to share our experience of cerebral palsy today, you have put yourself in that 20% category of people who have to do 80% of the work. And as you know, working with children with cerebral palsy is not easy. It's a difficult challenge for us all as professionals, but I think it's well worthwhile, both in terms of professional satisfaction, but also the service that we are doing to our society and our communities. So I'll just share my screen. Um, so everybody is able to see my screen. Great.
Yes, sir.
So the topic for today is orthopedic management in cerebral palsy, current trends and recent advances. I will also go through some of the basics because that's important, but I will also update you regarding how the thinking is changing with regard to the management of cerebral palsy. So we all know that it's because of a non-progressive damage to the developing brain, the central nervous system. But we also know that musculoskeletal problems do worsen as the child goes through their childhood and growth and development. And this is down to a fundamental inability of spastic muscles to be able to lengthen in proportion to bone growth. And if there are problems with bone growth also in children with cerebral palsy because they don't ambulate normally, but the proportion of muscle to bone growth is fundamentally disrupted in children with CP. And this is down to a dysfunction in satellite cells. And as you know, satellite cells are the stem cells of muscle that give rise through their division to serial sarcomeres. And as serial sarcomeres are added in skeletal muscle, that's how the muscle lengthens. So if there is a fundamental problem in the satellite cell, obviously that is going to affect the way muscle that is affected by cerebral palsy is going to lengthen. And there are some exciting new research work that's happening with regard to using newer generation biological agents to try and change or influence or improve this process at a biological cellular molecular level. So I think we are at the sort of cusp of another revolution where we may be giving some medicines to children with CP, which will reduce the severity of their contractures. So in regard to etiology and incidence, we know that for the last 50 to 100 years, the incidence of cerebral palsy has remained pretty stable over time, around 2 to 3 per thousand live births. But recently there is information from Australia that their incidence is actually decreasing as a response to improved perinatal care. By perinatal, I mean also antenatal and postnatal. And these are the three main etiological causes of cerebral palsy. And you can see how this is a slide I borrowed from my neonatologist. They have shown massive improvements in both the survival rate of extreme premature infants, but also survival without neurodevelopmental impairment. So both of these parameters are improving thanks to better perinatal care. And how are they doing this? They have got an absolute host of measures that they are implementing in the neonatal intensive care units. Even before the child is born, with antenatal steroids, delayed cord clamping, magnesium sulfate administration, antibiotics, extreme premature babies are getting whole body cooling, but also simple measures like kangaroo mother care. So a host of different measures that are being implemented antenatally, um, perinatally, and postnatally is going to have a huge impact, a positive impact on our practice. But the fact is that in a developing LMIC country like India, um, the percentage of the population that is covered by good high quality tertiary neonatal care services is only now increasing, and as a greater proportion of the population is covered, we will find that the total number of children with CP will increase, but hopefully those children who do develop CP will develop a milder form of the disease so that we can provide better care for them as they go through childhood. So I want to start off with one of our fundamental anchors in terms of CP assessment, which is the GMFCS classification. I'm sure all of you know the GMFCS levels from 1 to 5 based on the child's mobility. You must also be aware that there is a slight change in the functional ability of the child, even within a GMFCS level, as they grow from early childhood through adolescence into late teenage years. There is not much change at the extremes, levels 1 and 5, but there is change in 2, 3, and 4. And this is just part of the natural history as they um, volumetrically expand during the teenage years, they put on more weight. There is a reduction in their power to weight ratio, and they become proportionately weaker. And this obviously has a lot of implications on our treatment strategies. This is the next classification, functional classification system that came about, which is the manual ability classification system called MAX. All of these charts are freely downloadable from the internet, so you don't have to write down or record anything. Just remember the names. So these were the first two, the GMFCS and the MAX. MAX basically gives you a measure of upper limb function. And now we have three more functional classification systems: the communication function classification system, the eating and drinking one, and the visual function. So from one functional classification, we have now gone to five. And but thankfully, all of them follow this level 1 to level 5 scheme, level 1 being the best performers, and the level 5 being the most severely involved children. And I think what this whole grid or framework of functional classification systems is going to do is that it provides us a validated scale for all the major functional domains in a child. It standardizes communication between professionals, and I'm sure it will revolutionize the way we assess children as professionals, but also have a tremendous positive impact on the mobility, the rehabilitation potential, the activity levels, and the participation of children with cerebral palsy. So before we go into the main orthopedic treatment, I have a mental checklist. Whenever I see a new patient with CP, I have a mental checklist, and I thought I should share this with you. Every child with CP should be diagnosed by a competent professional. Even now, we see many children who are wrongly diagnosed as CP. They have other neurological problems. So that will again profoundly impact if we get the basic diagnosis wrong. So a pediatric neurologist or a developmental pediatrician or a pediatrician with an interest in pediatric neurology should see, assess, and diagnose the child properly. Children should be seizure free. That is very important. If your child has seizures, whatever therapeutic or surgical treatments we try, they are likely to fail. So seizure control is important. All children should have access to regular therapy. The frequency varies depending on the needs of the child. It can be once a week, several times a week, once a month, whatever. But there should be regular access to physical therapy, occupational therapy, speech therapy, etc. Orthotics, never forget orthotics. Always think, would this child do better if we provide something as simple as an AFO? An orthopedic surgeon is important. Um, and I'm not just saying this because we are in the orthopedic community, but truly, I think the sooner and the earlier we assess the children, the better the outcome will be. Vision is another important thing. School is the child in school. Many children are not in school, and they should be. Every child of school going age, regardless of their level of impairment or disability, should be in school for better education and social skills. Make sure they get a government disability certificate. It will help the parents greatly to access whatever help the government is able to provide, and also see if there are any state government schemes that can provide some financial help to the children. There is the National Niramaya scheme, of course. It's a little bit on and off, but well worthwhile keeping these 10 points in mind. And this is applicable to all children with cerebral palsy. Lastly, motivate the parents to fight the good fight. It's a long and hard battle for them. And as professionals, I think we should provide them some positive feedback in order to keep them motivated, because it's a very long journey. Moving to the management, I think the fundamental um, principle to remember is that all children with CP need active management regardless of wherever they are, regardless of their geography, regardless of their GMFCS level, anything and everything. All children with CP need active management. They should be in touch with professionals all the time. If that happens, their overall outcome is better. From an orthopedic standpoint, our management primarily depends on three factors: age, GMFCS level, and the type of motor disorder they have, by which I mean whether they have spasticity or dyskinesia or ataxia or hypotonia. Now let's get through this motor disorder thing first. So this is a 12-year-old girl who has dyskinetic CP bilateral. She is probably GMFCS level 3 or 4. She has got so much movement problems that my camera can't even focus on her. But clearly you can see that she has severe impairment in her overall mobility. And this girl came to me because 3 years prior to seeing me at a fairly reputed institution, she had undergone some surgery. And you can see that in the discharge summary, they have documented very clearly that the Achilles tendon was lengthened with 2 lateral cuts and 1 medial cut on the right side, and 2 medial and 1 lateral. So they have been very, very specific and detailed in the way they have conducted the surgery, but they have forgotten that this is a child with dyskinetic CP. And perhaps it was not the best idea to perform orthopedic surgery on her. So always consider what is the principal movement disorder that the child has prior to intervention, just as you would consider what is the diagnosis. Does this child really have CP? So these are all fundamental questions that need to be asked before we actually move to the orthopedic assessment. So I like to look at the entire childhood of the um, child with CP in 3 main stages. And this is guided by what was produced from Canada, the same group that produced the GMFCS classification, um, Professor Rosenbaum, and this is called the motor growth curve. This is again downloadable from the CanChild website. And what they showed is that if you plot GMFM 66 on the y-axis against age in years on the x-axis, the 5 GMFCS levels mature at different times and to a different extent. But you can see a clear pattern that is there for all 5 categories. And then GMFCS levels 2, 3, and 4, as we saw earlier, as they go through the teenage years, their GMFM score actually goes down a little bit. So you have the first stage from 0 to about 6 years, when the child is getting better. There is a significant and rapid improvement in their overall motor growth. And then 6 to 12 years, you can see there's a plateau. These are called the stable years. And then between 12 and 18 years, as they go through the pubertal growth spurt, some of them, particularly the 2, 3, and 4, are getting a little worse as they are getting heavier and weaker. So how does age impact on our treatment planning? So you can see that by about 7 years, all GMFCS levels, they have completed motor maturation. They have reached the plateau. And it makes sense that until they reach that level of complete motor maturation, we should not do any irreversible intervention. So we should do reversible measures like therapy, orthotics, casting, and botulinum toxin. So these are all reversible measures that will provide temporary relief, but that's all we need, because the child's motor abilities are changing significantly during this time. So you should consider surgery only after the age of 7 years, once motor maturation is complete. And an important message is not to operate on 4-year-old toe walkers, um, as inviting as that prospect might be. So during the first 6 years of life, all children with CP have rapid motor development, and they will reach a plateau by the end of it based on their GMFCS level. This is the age at which diplegics typically start walking between 4 and 5 years, particularly the GMFCS level 1 and 2. The level 3s may start walking by 7, 8, or 9 years with support. During this time, if you correctly manage them, contractures seldom occur. So in most of the children, maybe 70% of children, you can manage them without contractures. And the principal motor problem at this time is spasticity. So let's look at spasticity. It has a natural history. Yeah, it has a natural history. This has been documented in several well-controlled population-based long-term studies, mainly from southern Sweden, Dr. Gunnar Hagland and colleagues, and they have shown that spasticity in children with CP is normal to low at birth. It steadily increases up to the age of 4 or 5 years. I call this period spasticity max because this is when typically children come when they are walking on their toes and the spasticity is predominating. This is when the parents come to us for some advice and potential treatment. But once they cross the stage of 4 to 5, then spasticity naturally decreases over time, reaching a low point by about 12 years of age. So this is a natural progression in the severity of spasticity over time in all children with CP. So this is an example of a 6-year-old boy. He's a toe walker. He does not have any contractures. When you put him on the table and have him nice and relaxed, he has got adequate range of movement in all his joints. But the minute you put him, tell him to start walking, you can see that the spasticity comes out in its to its fullest extent. So this is just spasticity, no contractures. And but this is another girl, 5-year-old girl, who came to me because they had been recommended surgery. And in this girl, again, spasticity is predominating. But in addition, when I examined her, she had a 5-degree equinus or selective gastrocnemius contracture in the left ankle alone. That was the only finding. Otherwise, it was largely spasticity. So this is a child who is still in the first stage, but she is starting to develop a contracture. So what do you do about this? So we chose to give botulinum injection to her left gastrocnemius and gave her a cast for about 3 weeks. And this is her walking with a heel toe or a foot flat gait pattern. At least she's able to get her heel down 6 weeks after the injection. So how to give the Botox? There are 3 golden rules that everyone should follow. First is to give an adequate dose, and this has been highlighted by multiple studies, 6 units per kilogram per muscle in the lower limb, around 2 to 3 units in the upper limb, and you could go as low as 1 to 2 units per kilogram per muscle for the small muscles of the upper limb. The second is procedural sedation. Botox is administered in multiple sites. It has maximum effect when it is given in multiple sites. So procedural sedation is important. Please do not administer Botox to a screaming child. And some form of guidance is important so that we administer the toxin into the correct muscle. Because if we put it outside the muscle, Botox does not diffuse because it's a high molecular weight protein. So it is important to give it into the right muscle. You can use EMG, some kind of electrical stimulation or ultrasound guidance. This is a video of me administering Botox into the gastrocnemius. You can see that the thickness of the gastrocnemius is only 1 centimeter. So it's a very thin muscle. In a 4-year-old, you could easily penetrate through the gastrocnemius into the soleus or administer it somewhere else. So some kind of guidance is very important when administering Botox. And this is the same girl at age 10. I've had the opportunity to follow her up for a much longer period of time. And you can see that she has maintained a fairly good gait pattern with just a single dose of Botox. There's another boy, 4-year-old, toe walking, mainly from spasticity. And 4 months post botulinum toxin, you can see that he is walking with a much improved gait pattern. He also had therapy and um, splints in addition to the Botox. So the key message here is that CP can be managed without surgery successfully in children less than 7 years of age. But Botox has its downsides, as has been highlighted by multiple articles from reputed institutions. It, if you give multiple Botox injections, it causes weakness, muscle atrophy, muscle fibrosis, and there is a small risk of adverse events. Particularly if you give it into the neck muscles, it can cause problems with swallowing and breathing, but those are all very rare. The main problem is muscle weakness and permanent muscle atrophy. So I would advise judicious use of botulinum neurotoxin, perhaps no more than 1 to 2 injections in the during childhood. But in spite of all the pros and cons, I would say that it is a valuable tool to delay surgery until motor maturation is complete, which is 7 to 12 years. Next, we move to the second stage, which is 7 to 12-year period. Here, motor and gait maturation have completed. They plateau if they have been managed appropriately in step 1. Contractures can occur if spasticity is not fully controlled, and this is the ideal period for operative intervention where indicated. So the ideal management is to do a detailed multidisciplinary assessment of the child at about 7 years. This will include 3D gait analysis in walking children, children who have a functional gait pattern. And based on the gait analysis, we plan for gait improvement surgery. Now, there was a term called SEMLS, single event multi-level surgery. And I think everybody is moving away from that SEMLS terminology, because we are finding as we follow these children up later on in life, some follow-up surgery is required in many of them. So it's not necessarily a single event surgery, it's a multi-event, multi-level surgery. So we have changed the terminology to gait improvement surgery. And all children should have intensive post-op therapy, both in the hospital and at home. What is gait analysis? Is basically a test like an MRI scan or an ultrasound scan. It is a test of walking parameters. We look at various objective data like step length, cadence, walking velocity. We capture the movements of joints in 3D. It's called kinematics. We measure forces going across the joint called kinetics. We also use things like dynamic EMG, which helps us to pinpoint which muscle is malfunctioning, which is the cause of the gait dysfunction. This is a photo of a gait lab. We have infrared cameras that capture the movements of joints in 3D. We have optical cameras to give us 2D videos. We have a force plate on the ground that tells us the ground reaction vector. And we have a very powerful computer that analyzes all this data. So why do we use 3D kinematics? Because the typical child with CP has problems in the sagittal and transverse planes. So when you have flexion of joints along with torsion, then your perspective changes, and this can affect your assessment of how much of movement is happening at a particular joint. So this is a child undergoing a gait analysis. We stick these markers on the skin. That's a dynamic EMG probe. And then when we shine infrared light on these markers, they show up as bright points in space. This is then converted into a 3D biomechanical model. And then we get the ground reaction force vector, and then we get all this graphs, which helps us to plan the surgery. So gait analysis gives us the surgical plan without much guesswork. So why do we use gait analysis? Because clinical exam findings do not always correlate with gait abnormality, and the human eye is incapable of capturing discrete events at a rate greater than 18 frames per second. And this is an absolute limit. So just like an umpire uses DRS, or they use slow motion camera to decide whether a player is out or not, in the same way surgeons are using gait analysis. And the child with CP requiring orthopedic surgery has problems in multiple planes and at multiple levels. And excessive and inappropriate surgery used to be a common problem in children with CP. And therefore, we are using technology as an aid to improve our decision making. So this is an old problem. So this is Aristotle's classic treatise from 2000 years ago called De Motu Animalium. And because he didn't have a video camera with him, this is how he depicted a horse moving. He thought that the horse moved like a human being. right limbs forward and then left limb forward. But actually horses move in a very different way. They stretch both forelegs and hind legs outwards, and then they bring everything together. And this actual movement, the way the horse gallops, was only captured in the late 19th century when we actually had motion picture. So even someone as intelligent as Aristotle, if they don't have the particular tools, the correct tools, then um, we can make fundamental errors in our understanding of movement. And this is just a homage to Professor Jim Gage, who is the father of modern gait analysis. So the future of gait analysis is no longer in the lab. So we have these matchbox sized um, units called inertial measurement units. You basically tie them with straps to the legs or any part of the body you want to analyze. So there is no fixed location. These inertial measurement units transmit all the data to the computer or even to your mobile phone wirelessly. So this happens in real time and at high speed. So you don't need a lab really. You can do it in your outpatients, or you can do it out on the field in the school playground if you wish. So this sort of technology is coming, and it is coming to India. And this is Gunjan Patel, who actually works with Dr. Dhiren, and they are trying to develop a very low cost, um, simple, easy to use gait analysis system that can be used in your therapy center. And you can see this video where they are just using the mobile phone to capture all the data, and this will give you a 3D gait report. And this technology is not far, maybe a couple of years away from commercialization. So the next stage is markerless movement analysis, when you don't need markers at all. Using AI, we're going to have complex algorithms that will give us 3D data just from 2D videos. Um, the technology and the models that we have, the biomechanical models, they are not perfect yet, but I'm sure it's only a matter of time before this milestone is also reached. And there's a lot of clinical evidence, many papers that show that the overall outcome, the clinical outcome from surgery, is vastly improved when 3D gait analysis is used. There are loads of papers in the literature regarding this. Moving on to surgical management, there are three main surgeries that we perform as surgeons. The first is gait improvement surgery, which used to be called CEMILS. We have crouch correction surgery and hip reconstruction surgery. And these three are meant for three different groups of children with cerebral palsy. Gait improvement surgery is predominantly done in GMFCS levels 1 and 2, typically between 8 and 11 years of age. Crouch correction surgery is typically done in GMFCS level 3 during the adolescent years. And hip reconstruction surgery is done at any age, predominantly for GMFCS level 4 and 5 children. And this is to prevent permanent femoral head deformation. So a quick word about percutaneous surgery in cerebral palsy. I'm sure many of you would have heard of this. Unfortunately, this causes greater harm than good. It's called by various names, and there are lots of abbreviations for this kind of surgery. But most of these percutaneous operations tend to over lengthen the muscle tendon unit, which is irreversible. And even though it may be attractive to parents as being as because they are all advertised as being minimally invasive, one must be aware that the needle can cause greater damage than open surgery, because the surgeon has no control over how much the muscle or tendon is lengthened by. And this is a case of iatrogenic recavatum. So this is a child who was walking fairly normally with a little bit of knee flexion and then had over lengthening of the hamstring. And this is disastrous for the child because such over lengthening is irreversible. So this is the modern gait improvement surgery where we correct lever arm dysfunction. This child has persistent femoral anteversion resulting in in-toeing gait. You can see that she's walking very slowly and very carefully because she might trip and fall over. This is 2 months after a simple femoral derotation osteotomy. You can see that her walking velocity has improved. She's a lot more confident and walking a lot better. So simple, well-timed operations that address bones rather than muscles is the latest thinking with regard to surgical management. We also have um, foot deformities, which are quite common, particularly in hemiplegics. This is a boy who had at about 6 years came to us with severe equinovarus because of tibialis posterior contracture and spasticity. We did a split tibialis posterior transfer, and 2 years later, you can see that he's a lot better and he's free of orthotics now. So hamstring lengthening for crouch gait is another commonly performed surgery. And again, we have to do this with caution, very judiciously, because we could easily over lengthen the hamstring. This causes anterior pelvic tilt, recavatum gait at the knee, lumbar hyperlordosis, as you saw in the previous example. And many of these children develop severe low back pain during adult life. And because of this severe low back pain, they stop walking. So rather than cutting muscles, we tend to transfer muscles these days to preserve their power at the hip. And we do careful medial hamstring myofascial recessions. And it's important never to release the biceps and the lateral hamstrings in walking children. So this is a boy who GMFCS level 2 with severe crouch gait. He didn't have much contracture, so we just did a soft tissue release and casting. And then a year later, you can see that he's standing a lot better. But you must remember that he went through a lot of rehabilitation. You can see him working in the gym, doing a lot of work. And this is another child again working in the gym. I send all of these teenage boys after their surgery to do a lot of muscle strengthening exercises in the gym. And I think boys particularly respond a lot more to the environment of the gym with the music and all that, and seeing other, able-bodied young men working out. I think it's the rather than being in a therapy center, though I think they should go at least once a week to a therapist for some direction and advice. I think primarily these people should be in a gym. So this is a more severe case of crouch where this child had um, a 30-degree fixed knee flexion contracture, and we did femoral extension osteotomies in 2 years post-op. You can see that he's a lot better. So the milder um, hamstring tightness can be managed with judicious hamstring lengthening, but the ones with established knee flexion contractures may need bony surgery, and this is what we do. So this is a child with a knee flexion contracture. We remove a wedge of bone, and then we straighten the knee, and we also pull the patella down in order to retension the quadriceps mechanism. And this is a typical post-op X-ray that you see after crouch correction surgery. This is a distal femoral extension osteotomy, but this is in the child who is skeletally mature. In younger children who have knee flexion contracture, we can do something called growth modulation. These are minimally invasive surgeries where we just put a screw or a titanium plate in the front of the femur, and this allows the back of the femoral growth plate, the distal femoral growth plate, to grow faster. And as the child grows, within 12 to 18 months, you get full correction of the knee flexion contraction, and the metalwork can be subsequently removed. The other lever arm dysfunctions that are common is the so-called midfoot breach, which typically happens along with crouch gait and external tibial torsion. And I'll show you a case example of a boy. So this is a 12-year-old boy. He came to me is almost 10 years ago with diminishing knee function, and he had a 20-degree knee flexion contraction on the right side. So he underwent a left hamstring lengthening and a right femoral extension osteotomy, and I also corrected his midfoot breach. 3 years post-op, you can see that he's put on a lot of weight, and he's walking a lot slower, and he had some residual external tibial torsion. And then this is him at age 19. He's in college. He's able to walk a kilometer, but he's actually complaining of knee pain on the side where he has full extension. So he has almost full extension in the right knee, and he's actually complaining of knee pain on that side. And I'm thinking whether to leave these children with a slight degree of knee flexion may actually be better rather than pushing them into full extension. The last topic I want to discuss, and perhaps one of the most important, is the problem of hip displacement in CP. This is the normal progression of femoral anteversion. Children at birth have femoral anteversion of 40 to 60 degrees. By age 5 years, it comes down to about 25 degrees, and it reaches about 10 to 15 degrees by skeletal maturity. So this is the normal progression. And there was a very elegant study done in Melbourne, which showed that there was a fundamental failure of remodeling of the proximal femur in children with cerebral palsy, and the amount of the extent or the severity of this problem was again directly proportional to the GMFCS level. So somehow, the greater the functional involvement of the child, the more this failure of remodeling of the femoral anteversion and the femoral neck shaft angle. So slide on the bottom left shows how GMFCS directly increases in proportion, or hip migration increases in proportion to GMFCS level. But now the Melbourne group have shown that the neck shaft angle, which is the amount of femoral valgus, and the femoral neck anteversion angle, which shows the amount of anteversion, also increases as the GMFCS level increases. So increased neck shaft angle and anteversion of the proximal femur due to impaired mobility may represent the fundamental pathological mechanism by which hips displace in cerebral palsy. So we know that children who do not walk properly, their hips displace. We used to think that spasticity was the problem, but we know now that spasticity is not the issue. It is because of functional level or the extent of ambulatory potential of the child. And what happens is, when the child doesn't walk, there is abnormality of proximal femoral geometry, and this causes hip displacement. So this is the latest thinking with regard to why hips displace. So Reimer's migration percentage, I'm sure all of you have heard of. It is a validated and reproducible measure. So this is the way to do it. Draw the Hilgen-Reiner's horizontal line, draw a vertical line which is perpendicular to the horizontal line on the medial edge of the femoral epiphysis, one on the lateral edge and one along the acetabular border. So that is X proportion outside the acetabulum divided by the total width of the femoral head or the femoral epiphysis, gives you the Reimer's migration percentage. And a single measure of RMP is not as significant as changes in the RMP over time and how stable it is over time. So hip displacement risk, is determined by the GMFCS level, and severity of spasticity does not predict hip displacement. So as GMFCS level goes up, the risk of hip displacement increases. So our treatment options are many, and we will look at whether these treatment options work or not. Non-operative treatment should be tried in all children. A regular standing program, appropriate postural management of GMFCS level 5 children, abduction orthosis and botulinum toxin, though they have not been shown to change the overall fate of the hip, it may help to delay or postpone the need for surgery. And even that I think is a valuable addition as an adjunctive measure. In younger children, we perform soft tissue surgery, release of the hip adductors and the psoas. In older children, we do bony surgery, but there is no consensus in the literature as to when and whom to operate on, though most children who have a migration percentage of more than 40% will perhaps, most surgeons will agree that 40% is a threshold, but there are few studies with long-term follow-up to skeletal maturity that can really give us firm evidence-based guidelines as to when to intervene. So example of a 3-year-old male came to me, GMFCS level 4, his migration percentage is already more than 50%. So I elected to do a soft tissue release. This was some 7-8 years ago. And whenever you do soft tissue release, you should always do it bilaterally, because if you do a unilateral adductor release, within 12 months, there is a high risk of the contralateral side also displacing. So this is the pre-op hip abduction, less than 20 degrees. Post-op hip abduction after the release, you can see, is much better. And this is him 12 months post-op. The Reimer's migration percentage has come to less than 30%. This is him at 2 years. You can see that the migration percentage is gradually increasing. And this is 5 years post adductor release. You can see that he is back to the Reimer's migration percentage of 50%. And now he is actually 8 or 9 years of age. And therefore, he is much older. He will need some kind of bony surgery, but then he's much older. And that I think is the main effect of soft tissue surgery. Various authors have shown that there is a reduction or delay in the need for major bony reconstruction if you do preventive orthopedic surgery in the form of adductor and flexor release. But the main paradox is that children who are GMFCS levels 4 and 5 are the ones at highest risk of hip displacement. And unfortunately, these are the children who least benefit from soft tissue surgery. But it may help in these children in terms of postponing the age at bony reconstruction rather than the need for reconstruction. So in bony reconstruction, we do a varus derotational femoral osteotomy, we do shortening of the femur, we reduce the neck shaft angle to somewhere between 90 and 120 degrees, and we also perform an acetabuloplasty. These are all major surgeries. If it is done properly, they have very reliable and very gratifying long-term outcomes, but there is a whole host of complications. These are not easy surgeries to do. Respiratory complications, loss of fixation because they have osteopenia, infection, redislocation, pressure sores, windswept deformity. There is a whole host of problems. So, if at all possible, if we can perform these operations on older, fitter children or not perform bony reconstruction at all, that would be in the best interest of the child. A newer treatment has come in the last maybe 5 years, which is proximal femoral growth modulation. This is a very minimally invasive surgery and it reduces the neck shaft angle by slowing down the growth of the medial part of the femoral head. And it is done in those children with progressive subluxation who at least have 2 years of growth remaining. And studies have shown that there can be a 10 to 15% improvement in the RMP over 2 to 3 years. And this can be done as a primary procedure, or it can be combined with an adductor release, or even after hip reconstruction surgery. And this is an example from the literature. We have just started doing it for the last 2 years, so I don't have a long-term follow-up of my own, but this is a case from the literature that shows that the technique does work. But you need to perhaps, if you do it in young children, you have to exchange the screws every 3 years or so. And in some children who have associated acetabular dysplasia, you may have to do a pelvic osteotomy. But this is a newer technique that is showing a lot of promise. And these are the salvage surgeries, proximal femoral resection and valgus osteotomy. I think I only mentioned these operations because, or to be condemned because I don't do these operations. They have a very high complication rate, and the patient satisfaction rate with these salvage procedures is very low. So how do we address this problem of hip displacement in CP across the population? The only way to do it is to have a hip surveillance program. This should be started when the child is between 12 to 24 months of age, or as soon as possible after diagnosis. Frequency of follow-up depends on the age, the GMFCS level, clinical examination, and the Reimer's migration percentage. Remember that group 4 hemiplegics who are GMFCS level 1 have a risk of hip displacement in adolescent life. And basically, we are targeting those children who have early hip displacement so that we can do soft tissue surgery on them and postpone the need for bony reconstruction, identify and treat um, hip dislocations at an early age, and basically abolish the need for salvage surgery. That should be the main goal of a hip surveillance program. And I would recommend anyone who doesn't know about this app, it's freely downloadable from the Play Store or the Apple Store. It's called Hip Screen, and it gives you all the tools, all the information necessary to have a hip surveillance program. I'm proud to say that IACP was at the forefront of developing our own Indian National Hip Surveillance Guidelines. And after almost 1 year to 18 months of work between a lot of sister organizations, including our own POSI, we were able to produce guidelines that are specific to India. So hip surveillance is basically a schedule of regular clinical and X-ray examination that can identify silent hip problems so that you treat hip displacement earlier and more effectively. And they have shown that in southern Sweden, over a 20-year period, you can eliminate hip dislocation. So that is also possible. Maybe we are quite a way away from that, but it is possible to eliminate hip dislocations. So this chart basically tells you, according to GMFCS level, at what ages who should have a clinical examination and who should have a pelvic radiograph. And it's very useful. And this is downloadable from our POSI website. The address is below. Just go to the POSI website and you can download this chart. Just print it out and put it up in your outpatients or in your office. so that you have it as a ready reckoner. You refer it to pediatric orthopedic surgeon when the migration percentage crosses 30%, or there is reduction of hip movement, or if there is any hip pain. And the hip screen app also gives you some guidelines about how to take a proper X-ray. So hip problems are common in children with CP. Many hip displacements go unrecognized, unfortunately, because it can be a silent problem. All clinicians should use the hip surveillance guidelines in their day-to-day clinical practice, and our aim and our goal should be to reduce the need for major reconstructive and salvage surgeries. So start at about 18 months. Under 5 years of age, if you get significant displacement, you can do soft tissue release. At an older age, you can use this newer medial proximal femoral screw. Older children may need hip reconstruction surgery. And at skeletal maturity, some children, a small proportion, may need a little bit of adjustment to keep their hips in. What we are trying to do is stopping these children from falling off the ladder of containment into the jaws of salvage surgery. So the last stage, which is 12 to 18 years, is when they go through their rapid pubertal growth. Ideally, we should not do any surgery at this time, because education and integration into the community, into society, becomes more important. And in any way, in any case, teenagers are not a very good rehab candidate. So I want to summarize my talk by saying, remember the 3 cardinal stages of development in a child with CP. 0 to 6 years, when spasticity predominates, our goal should be to prevent contractures. This is the age of the therapist. 6 to 12 years, when we do our gait improvement surgery, about 30% of children will need surgery. This is the age of the surgeon. And 12 to 18 years, this is the age at which some children with GMFCS level 3 go into crouch. At this time, we should avoid surgery. They should be in school, and they should be in the gym, strengthening their muscles and preventing weight gain. And this is the age of the teacher. Just a quick vignette. This is a 4-year-old boy who presented to me in 2016, having just started walking. We gave him 1 Botox injection into the hamstrings and gave him regular therapy and orthotics. This is him 3 years later at the age of 7 years. You can see that he has got lever arm dysfunction. He underwent gait analysis, and on the basis of the gait analysis, he underwent gait improvement surgery. And this is him a year later. And this is a video that his father sent me during the lockdown of him being at his fullest potential. And he is now around, I think, 11, 12 years of age, and he is doing really well. He's going to school, and this should be the aim of all professionals, to work together to maximize the ability and functional participation of children with CP. Thank you very much. I
Yeah,
hope I've
Jayanth, excellent.
gone over time.
Yeah, that's okay. But like, you gave a complete overview of the topic, and this is something like Gita or Quran or a Bible in just 50 minutes. So that's an excellent summary of the what is recent in cerebral palsy. We have few questions, so let me see the chat, and then we will try to uh, one by one. So the first one is, can you suggest affordable robotic rehab equipment for pediatric? That's the first question. Um, do you consider that as your specialty, or you would like to?
Actually, we have been working with the Department of Defense, the DRDO, the Defense Research and Development Organization in Bangalore, and they have actually been developing an exoskeleton for Jawans. And they have actually managed to produce a good prototype now. And we have found that that same exoskeleton is very useful for rehabilitation also. So it was primarily the project was to provide Jawans who are working at high altitudes the extra ability to be able to carry their loads, because they find it very difficult to do that. But I think we might have an Indian, made in India, robotic gait system, an exoskeleton, which will actually be helpful for children not only with cerebral palsy, but also stroke, adults with other movement disorders. So I think watch this space. I think the scientists and the engineers are working hard at this problem. The current systems are way too expensive for the Indian setup. Though I know that there are systems available in Mumbai and in Hyderabad. Um, so it is robotic gait trainers are available in India, but I think the capital cost is really high.
So all these trainers are for the physiotherapy department. They are not for patient to use at home. Probably, I think the video become very viral during the last Olympic at Paris. The person with a paraplegia carried a torch, Olympic torch, with this type of caliper, robotic
Yeah.
caliper. So probably yes, something is in pipeline, and as you rightly said, that in next decade, probably we will be able to have something better. The next question is when a CP child aged 15 years has dislocation by birth, how best can I help to walk? Very
So it's a orthopedic question, and it's a complicated um, answer. Basically, um, it all depends on the GMFCS level and what is your functional goal. Um, if the child is already walking, then you need to ask, is the hip dislocation interfering with the child's ability to walk, and by how much? Because to fix a congenitally dislocated hip in a 15-year-old is not easy. It's a very, very difficult problem. And if the hip is painless, I think it may be better to leave it alone, because just the intervention may make an otherwise painless hip into a painful hip. And it is a very long and complicated operation with a lot of um, post-op potential adverse events. So this is one situation that I think even the most experienced surgeons would tread very carefully before deciding to offer any surgical intervention.
then there is a question about the upper limb surgery. So you have not covered that topic, but would you like to cover
Yeah,
that?
yeah. So I know that my topic did not cover three things. The upper limb was one. The second was the scoliosis, and the third is the role of selective dorsal rhizotomy and intrathecal baclofen. But I can offer all the viewers today, the delegates today, um, some good review articles. So I will be sharing these review articles with Dr. Mallikarjun, and hopefully these are all free full text articles, so they are not subject to any copyright. So perhaps they can be shared to all the ISCP members. Um, so that gives a very good overview of these complex topics. Um,
Okay. The next
so,
question is about
but upper limb is a very well developed and well characterized domain within cerebral palsy surgery, and we do offer treatment for upper limb problems.
yeah. Then the next question is already you have covered, but still it's very important that you re-emphasize the point. What are the red flags for conducting surgery in cerebral palsy kids?
The first red flag is dyskinesia,
Yeah,
any
exactly.
kind. So any movement disorder other than spasticity, you have to be extremely cautious. Number one. Number two is always ask yourself, is this cerebral palsy? That is another fundamental question to ask. Whether this is cerebral palsy, be absolutely sure and take help from a good pediatrician or pediatric neurologist before you reach that conclusion. Number three, make sure that the child has good strength, because the weaker the child is pre-op, the less predictable the outcome post-op. And look at all the logistical and societal, social, financial, all the challenges that you are likely to face in the post-op period. Anticipate all of these pre-op and try and correct them as soon as possible before the surgery. Because I always tell parents, once I do the operation, it's like a roller coaster. The roller coaster starts rolling down, and you cannot stop a roller coaster. There is absolutely no way you can stop it. It will just roll down the hill. So whatever seat belt you want to do, prepare yourself for that roller coaster ride. You better do it before you get to the top. So I think a lot of good communication between professionals is very important. Good communication and counseling of parents is important, and being honest with yourself as a surgeon as to whether really you're going to make a difference to the long term function of this child and the activity and participation of the child. I think i think a lot of honesty and humility is needed before one embarks even on the most simple cerebral palsy surgery. You need to be humble and think of yourself not as some kind of knight in shining armor who is going to come and transform the life of this child, but make small meaningful improvements in return for small meaningful contributions from the parent and the family. I think those sorts of surgeries actually in my experience have been the most gratifying for me, rather than taking on some very complex surgical challenge that has a lot of pitfalls along the way. I've always regretted those experiences.
Yeah, Jain, then there is one very good question, and I think that we really need to clarify. You that the question is like you mentioned in your PPT that surgery should not be performed about 12 years. So can you elaborate about that in little detail?
It is not that it should not be performed.
Yeah,
See,
exactly.
um, um, uh, one important proviso to my whole talk is rules are for fools. Wise men have guidelines. Yeah. So none of the things I said in my talk are rules. We are all wise men. Every single person here is a wise person, and regard these as guidelines. And even I break all these rules all the time, but I will think 10 times before I break a rule. But I do break them, but I know that I'm breaking a rule, and I know where I'm breaking it, why I'm breaking it. I do it in a very thoughtful way. So, not to say that you should not operate above the age of 12 years. In India, obviously, we have a lot of logistical challenges, and you may well get a child who's 14 or 15 who will benefit from surgery. So, absolutely go ahead and do it. But know that there are some pitfalls and some challenges there, because then you have a teenager who may not comply with rehabilitation, etc., etc. So anticipate those problems and start uh, thinking about it even before you do the surgery.
Okay, then there is a question about the maximum dose of Botox injection.
So I will be sharing an article regarding this. Um, the textbook answer is 12 units total dose. 12 units per kilogram body weight total dose. I think that is the safe legal limit that has been established. Beyond 12 units per kilogram body weight total dose, all the muscles put together, signs of systemic weakness start to come about. But I know many people who go up to 20 units per kilogram body weight. But between 12 and 20 units, I think you need to be really careful. You should not do them on GMFCF 4 and 5 children who might already have some problems with swallowing or breathing, etc. It might just push them over the edge. Um, so so I think up to 12 units per kilogram body weight is fine. And you can always do it sequentially. So do one lot of muscles, and then 3 months later, you go back and do another lot of muscles. Like that, you can do it. You can spread it out if you need to target more muscles.
Okay, then there is another important question. What is your preference for managing midfoot break in cerebral diplegia?
So this is a very um, um, contentious question. In fact, we are discussing it in detail. We have devoted an entire session to this during our next Pediatric Orthopedic Society meeting. Um, the I think the simple answer is, before you think about um, surgery, think about non-operative treatment and the age of the child, and try and postpone the surgery for as long as possible. Use um, good rehabilitation, good orthoses to try and hold the foot in a plantigrade splintable position. And any surgery should be done perhaps after the age of 10 or 12 years, when most of the cartilage in the tarsal bones has ossified, so the results are more predictable. Um, and the exact treatment depends on the GMFCS level of the child, what is the age of the child, what is the severity of the foot deformity, etc. We are moving more towards doing fusions of bones of the foot in the older children with severe deformity and doing osteotomies. The typical operation is called a Mosca procedure or a calcaneal lengthening of osteotomy. This is done, the osteotomies are done in younger children who have more less severe deformities. So ideal period to start therapy after Botox, start immediately, absolutely. So even though we do casting for 3 weeks after um, botulinum injection, um, we start them standing on the next day. Um, and even children who are in above knee casts after a hamstring botulinum injection, um, they get strengthening for the trunk and the pelvis and the hips. So whichever joint is free, start them as soon as possible, preferably the next day. Do a lot of standing, a lot of anti-gravity muscle strengthening, trunk and abdominals, pelvis and hip. You can do a lot of prone lying. So it's a lot of rehabilitation that can be done post Botox, even before you remove the cast.
Okay, so now there are no questions. So thank you very much, Dr. Jayanth. And I would really appreciate the initiative which Dr. Mallikarjun sir has taken, because at one point there were 100 participants in the Zoom meeting. So the full capacity of the Zoom meeting was utilized, and that really requires a big round of applause. So with that, I hand over to sir.
With a due apology, sir, I want to apologize all the participants. There were 510 registrations for this webinar. Due to the technical problem, we were unable to accommodate all of them. 100 participants directly came to live, and simultaneously there are many are watching on YouTube also. I really first, on behalf of all of ISCP, apologize all the participants who enthusiastically registered for this webinar, and I've been receiving so many WhatsApp messages from them. Sir, this is a wonderful learning experience. We missed it directly interacting with the Dr. Jayanth sir. I said, I promise you that I will again request him with a new other topic and to teach you whenever it is convenient for him. This is a really excellent workshop, sir, and I am sorry that initially when I was talking and introducing about National Cerebral Palsy Day, there was a power off in our society. Suddenly there was a switch off in the current, and I could not continue to speak. Um, Really, here I want to say that all three stalwarts are there, and one proud moment I would like to share with you is that our one of the founder member, Dr. Ashok Johari sir, was given awarded with a Hall of Fame from SciCord. It's a great honor to us, and that we wanted to share with all of you. I want to share with all my colleagues. These are the founder members of IACP, and Dr. Perin K. Mullah Firoza and Dr. Mahadeva sir is the founder and patron also. Dr. Ashok Johari, Dr. A.K. Purohit, Dr. G. Shashikala madam. With their mentorship and guidance, we were able to reach to this place today. And as you know that here we are very proud. This is a rare honor. What I had that occasionally is on awarded to the eminent professionals in the field of orthopedics by SciCord. It is a rare honor to ISCP and our pride to our nation also. And we have a series of workshops this month, and request all the participants to attend those workshops and learn directly from the eminent professionals. And thank you very much, sir. And I request Today we missed Dr. Dhruv. He tried his best to join the webinar, but due to technical problem, he couldn't join. So he sent an audio recording, but due to the lack of timing, and we are unable to play the audio. And I will share this matter with all the participants and ISCP members what Dhruv wanted to convey. Now I request, even we will share all the articles if you share with us to all the members of the ISCP and all registered participants. Regularly, periodically, we share the research articles with our members and registered participants and professionals who where we are having a database. Sir, this is I shall be. It is our pleasure to share your articles if you share with us. And I request Trupti Nikarge, who is our senior executive member, to say a vote of thanks on behalf of ISCP. Trupti?
Hello, everybody. Thank you, sir. I would like to thank Dr. Jayanth Sampath, sir. The question in the chat box itself speaks about the information in the lecture. It was really a very informative lecture, sir. Thank you so much. Thank you, Dr. Hiren, sir, for wonderful moderation of this session. And all the audience, thank you for your patient listening. And we look forward to you attending more and more webinars this month. Thank you all, and again, best wishes for the National CP Day. Thank you, sir.
Thank you very much.
Thank you.
Thank you, sir.
Thank you so much.
Thank you very much. Thank you, sir.
Thank you so much.
Thank you, sir.
Thank you.
Thank you. Good night.
Good night.
And we'll meet on 5th with our next webinar. Okay.
Thank you, sir.
Thank you, sir. Thank you and good night. Sir, shall I end the meeting?
Yes, sir.